on our keynote speaker, Dr. Beatriz Hornburg from Brazil for her extensive talk. Yes, madam, this stage is all for you.
Can I share my screen?
Yes, please do share your screen now, madam.
It's okay. Right. Everybody
Yes, your
see?
screen is visible and you are also audible. We can
Great.
start, madam.
Thank you very much. This is a great opportunity for me to speak with as a keynote, and I'm very thankful for all of that. And thank you for your patience for the next minutes. Actually, this is more as a sharing experience than actually a lecture. I believe that congresses are a great opportunity for us to share experiences, talk about ideas, and see what's next in our specialty. Well, I will talk a little bit about me. I am an anatomical pathologist. I live in Joinville, Santa Catarina, Brazil, and I own a laboratory called CDAP. It's anatomical pathology laboratory only. It's not clinical pathology. And it is a College of American laboratory accreditation program accredited for now 20 years. So we have significant experience in quality control this far. I am starting a consulting firm. It's startup, Starker Life. And I work with the Brazilian Society of Pathology as a member of the accreditation program. Actually, I was the author, and now these documents are really growing. It's really beautiful to see. We have around 53 labs subscribed to the program and 20 or something accredited. And I am also a leader inspector for CAP and the lab program and for the Brazilian program. I work also as an expert in quality pathology laboratory for City Cancer Challenge Foundation, which is sponsored, my part is sponsored by the American Society for Clinical Pathology. This is a very interesting foundation, and I will share a little bit about it later. So let's go on. Talking about challenges, right? Well, this is a great challenge. What? Horse rate? This is a pathology congress, right? Yes, but we will talk a little bit what happens in a racehorse. Anything can happen, and there is a huge investment. I believe in many countries there is it's something that's tradition, right? Well, let's go. Facts about horse races. As I told you, anything can happen and bring serious consequences. Like a horse can fall and broke a leg, a jockey can seriously be injured, and all of these have a great impact on the lives of the horse, the lives of the jockey, the lives of the teams, and everything. So, what about the race? Why we do that? We have to have a preparedness, a specific preparedness, like our laboratories. We have to have a preparedness for our exams. We have trained personnel. We have facilities that must be well kept. We need information here about the race, about the teams, the other teams, the best horses in the tracks, and so on and so forth. The reason we do that, it's the investment we made. We made investment in the horse, in the team, everything. The adrenaline of the victory, the prize that we expect with it all. For us pathologists, the investment is also huge in training and everything. And the prize we have it's a mix of our income and also the rewarding of being pathologists, being able to help our patients. And the other good reason for having a horse team is the reproduction of the champion. And we as well want to reproduce our ideas, want to make a school of with other pathologists and keep our specialty growing. The result, we have an expectation, the prize, what would be the end of the race, and so on. Sometimes it's a huge work that we have to put in, and sometimes the reality is not the one that we expect. Something can happen. And also the future is unpredictable, but it's a challenge, as I told you. The life is a race, and we cannot control what happens in a horse race. However, we can control some of the outcomes of our cancer patients. The consequences, considering still the injuries in the horse race. We have an incidence of 13 events per 1,000 starts, resulting in 2.9 deaths. That would be 117 deaths in 544 events. Most of the injuries are bone, usually broken legs, tendons and ligaments, other soft tissues injuries, and respiratory injuries, mostly lung hemorrhage due to excessive workout during the race. And one curious fact is that 70% of bone injuries will lead the horse to horse death. It's really impactful on those races, and it's a significant impact on the sport. However, we have cancer burden on society that it's much more, considering especially cervical cancer, which occurs in some countries as the first cause of death, and in a very age range of productive women, mothers, spouses, workers. So that's something we have to consider during all this. Okay, how can we control that? The race against cancer is really the one we pathologists must help our patients win. But it's really interesting because we are always very focused on our microscope, on our labs. But coming to an open vision of waiting times in cancer, as is a target of 62 days for the NHS in United Kingdom. This target must be reached, considering our side, by calling our doctors, because we pathologists have a huge data bank to allow us to reach the doctors. We must look out for our patients. Whenever calling the doctors fails, we look for our patients. This is really important. And ask for authority support. Here about cancer screening policies and complete patients' records and other equivalent documents in the health system. So having a waiting time from the time of diagnosis of the disease until the installment of treatment of 62 days would be really the ideal. However, in countries of the low and middle income in the world, this target is really difficult to achieve, mostly because some health systems are very, very fragmented, and also because logistics is very difficult for some countries. But considering the timeline of uterine cervix cancer, according to GlobalCan, the number of cervical cancers worldwide, cervical cancer cases worldwide will increase, right? And it's clear by the timeline, this is a fact. This year, in some countries, the cervical cancer is the 4th cause of death. In some countries in LMIC, it's the 1st and 2nd cause of death in women. By 2055, WHO, the whole, World Health Organization, predicts that in the only developed countries, we will have we will have here 4 cases per 100,000 women. But in low-income countries, this rate will be approached around the end of the 21st century. So this is a long way to go. But talking a little bit about the active search of patients, which goal is decrease the cancer waiting times and decrease cancer incidence and deaths. So regarding the country, each country will set screening policies that will be the base for setting the lab LIS, Laboratory Information System. These policies obviously will vary from country to country and even within the same country. Like some regions will have one kind of policy and others will have another kind. The system. Set the laboratory information system to look for patients suspicious or confirmed cancer. This is automatic search, right? After detecting those patients, we will send message forms, emails, anything regarding those cases, and we will alert our doctors. And whenever doctors are not available to us, we need to try to reach at any cost the patients directly. But I will talk a little bit about that. How we do that? Okay, it's very difficult because all of us have a super full agenda, and actually we are really focused and concerned in release timely, accurate, and correct reports, right? This is really, we can see it as another burden, but actually, if you look at it as a quality control characteristic, you will have a very interesting database to work with along the way. I will show. So, active search of cancer patients. It's a method for screening patients with suspected or confirmed cancers, using the LIS databank to monitor cases and alert the doctors of waiting times. It is based on local national policies for cancer screening. I did not detail this, policy here because it's something that it's national, but we can talk about that later in the presentation or after when you can ask questions. So during the last 5 years, we had in our laboratory an average of 80,000 cases of cervical cytology per year. So it's a kind of a plateau here, right? But this year from January 1st to September 30, we had only 33,000 years. Here in this part, we will have around 6,500 cases per month. And this year we had half of it. So this is the effect of the pandemic in our laboratory, because most of the elective surgeries and the medical offices, clinics, and so they were closed for a long time here in Brazil. And also patients, they are not going to the offices, they are avoiding. And now we have a second wave of the COVID-19 in our city here, but in many parts of Brazil. I believe in Europe, there are another wave of COVID too. So the impact is really interesting to watch. At one point in our laboratory, we had 75% less of the exams that usually we have. The characteristic of our laboratory is that we assist half of the public system and half of the private system in my city, which is about 80% of all the population is assisted by our laboratory. So, considering the public and private system, we had a total of 598 cases in 2016, about 900 cases in 2017, 419 in 2018. And here is a very interesting observation too. We had almost 2,000 here, an increase that is really interesting because it usually is related to the kind of population that we are assisting. In 2019, we always have the October pink, which is, I believe it's in all of the world or some countries, at least here in South America. The October pink usually is a campaign that we alert women to seek for medical attention and to go to the medical services for their annual pap smear. Here in Brazil, we still have more conventional cervical cytology, little bit of liquid-based, and very little of DNA HPV testing. And here is also a very interesting case because we have half of the cases and almost 3% of them are suspected or confirmed cancer cases. Probably because patients are delaying to the last minute to go to the doctors, and some patients will really have delay in their treatment, in their detection of disease. And another fact is that it's a personal opinion here. Because of the less cases that are going to health services, doctors and nurses have more time to examine more properly the patients. Here in the public system, we have a very heavy burden of the number of patients per day that can be and are attended so by doctors. So sometimes the cases are really huge number with about 15 minutes sometimes per each case. So it's really, really less. This is just a reasoning here. Well, considering the Bethesda system category, what was the number of cases by each category? So 600,000 atypia of undetermined significance, squamous atypia, 82 cases only of glandular cell atypia. Here, squamous cell atypia cannot exclude high-grade intraepithelial squamous lesion. Here, low-grade squamous intraepithelial lesions, and here, high-grade squamous intraepithelial lesion or more. In this category, we have 612 cases of pure HSIL, 55 cases of invasive squamous cell carcinoma, and 40 cases of adenocarcinoma, with 31 with other kinds of neoplasia. So far we have very nice indicator about how our population behaves in terms of having of incidence of cancer, right? This is certainly will vary for according to the population. In the south of Brazil, we have more resources and more accessibility to the healthcare system by the patients. In regions like Northeast and North, it's very difficult for patients to access the health system. And also the health system is very fragmented. Here in the South, a little bit better than in the other regions. South and Southeast is really the most resourceful regions of the country. Okay, how we reach our doctors. After the system sorted out the patients that need to be monitored, we send this kind of form to the doctors, yeah, with the patient's name and a whole bunch of patients' identification, the diagnosis, and here this is a characteristic of of Brazil, because we have so many similar names and equal names actually, that the name of the mother is one indicator of unique identification of the patient. So this is a law here that in every form, every health data, we have to have the mother's name. Well, according then to the follow-up of the patient alternatives, we ask here the doctors to check one or two or more alternatives if applied. So whenever the test is going to another or went to another laboratory, we will ask if there was an accordance. If there was not an accordance with our diagnosis, we try to get information on what lab was the test sent, and what was the diagnosis. Fortunately, here in my city, we have a very nice relationship with other pathologists, and it's really easy to get these other results. If the patient is already in clinical follow-up, but without an actual test, sorry, if the patient is already treating the disease, or if the doctor lost the follow-up of the patient. And then here we ask the phone number, at least the last phone number or address available to the doctor. Then he or she can write any other observation about the patient. The doctor's name, the sign, and the date. Here is really something that we like to go further, because it's really easy to stay in our lab and focus on our cases. But whenever we reach outside the lab, we can learn something new and reach more patients. So surprisingly, we have a very nice rate of doctor engagement in this program. In the last 5 years, we had 82.7% of forms returned to our lab, and 70+.3 forms that were not returned. And we will explore this a little in a bit. Right. The index of cases solved due to clinical follow-up, due the form, right? The doctor responded the form and sent back to the laboratory. So this was more than 70% of cases, and 27% of cases we do not have a clinical follow-up. What this means, that 25% of the cases were solved automatically by the laboratory information system. How? The system detected in a given span time another exam for the patient. That means that at least the doctor is following her up, right? It's something due to that. The other 2% of that 27 cases are the cases that we had to contact the patient directly. Considering the very start of the program here in our laboratory, that was in January 2000 to September 2020. So we have more than 1 million tests with 8,000 cases of suspected and diagnostic of cancer, more than 7,000 cytological atypia and low-grade intraepithelial lesions, high-grade and cancer. And here we had 33% solved automatically, like I explained before. 66.4 needed contact with the doctors with the active search form, and only 4% needed contact with patients. So this program is very effective. And the result is solving case, the rate of solved case from all this time is more than 90%. Some cases here probably are because the patients moved address and didn't return to any of the doctors available in our system, or changed cities or countries. But how we engage doctors to return these forms? First, logistics. Every time we, here in Brazil, some regions, we have to collect cases and deliver reports in the clinics and hospitals and so on and so forth. So the logistics is provided by the laboratory. In some areas, the patients already sent, take the specimens to their preferred lab. So logistics is one thing that doctors do not have to worry about going after the patients, because we will deliver reports, and with the delivering of reports, some forms at a given office. Statistics. When having stats about their cases, the doctors like to have their historical or their cases sent to the same lab, which is good because we can really take care of the patients, right? And I will talk about it a little bit further. And another thing is shared responsibility. Doctors do not need to worry all the time when their patients will return, or if their patients will return, because we will help them to monitor the cases. So we can put these three reasons to engage doctors to our program. But how about authorities to create cancer policies? Here is something that we have some trouble. First of all, we have to show them that the cost benefit of preventing cancer is cheaper than costly treatment. We already know that, but sometimes we need to show numbers, right? And another thing, dialogue. Technical approach combined with cost benefit, and try to open a door with authorities and dialogue with them about the need to create policies so that we can base our screening system. And the global perspective. WHO, the World Health Organization, Union for International for Cancer Control, and City Cancer Challenge are some of the foundations that are really concerned with the future of non-communicable diseases globally. And these entities this foundation sometimes can gather external investments in some countries, and this will persuade authorities to create policies for screening and cancer treatment, right? So, continuing, cost benefit. Whenever an initiative is implemented, it has to have an increment of strategy rate complementation between less than 1 to 3 times the gross domestic product in a country. Whenever this extra money expended to implement a new strategy goes beyond this gross domestic product, probably it's not a good strategy, or it's not a viable strategy. Sometimes the strategy is really good. But what is really the cost of cancer? First, I will have to say that here in Brazil, as it is a huge country, we have already this fragmented system. gathering data about the cost of cancer, about the cost of policies and so on is really, really difficult. Our system still do not have an integrated fashion so that the institution can share data. So that's something that you will see. It's very complicated together, but still, in one study from May 2014 to July 2016, where a microcosting study were made in one region, and here they use mathematical models to estimate the amount of burden or investment for the whole country. But we see here that the direct medical cost, and I will explore this a little bit later, is what is the heavy side of these expenditures. But what are the non-medical costs? In an interview, that would be two-way transportations for patients, food and accommodations. Usually we have cancer centers that are reference centers for some regions, and then the patients have to go there from another city. So dislocation, accommodation, and food are expenditures that must be included in this situation that wouldn't otherwise be made by these patients. The indirect costs are related to human capital, which encloses number of non-working days per capita income, formal and informal jobs that these patients had. Here, they interview the patients to see if these patients in this study would have formal or informal jobs. Social welfare and wages. So this would be the impact of cancer burden of the human capital. And an estimated annual cost per patient of $2,219 per patient, right, per year. It seems not a lot, but whenever you think in a population base of millions, that is a quite significant burden, right? Sorry. Talking about the direct medical cost, we will have here hospitalization, radiotherapy, outpatient chemotherapy, imaging studies, laboratory tests, and surgery. You see, laboratory tests are really non-significant considering all the expenses that cancer demands, right? And radiotherapy would be the most expensive in the treatment. This is for the perspective of the payer, right? What the public system are paying to the institutions that work for them, for the public system. And here, if you see the side of the institution itself, the cost is really bigger. And one thing here with the cost of chemotherapy and other resources, and here in Brazil, we have some, I don't know if the name would be in English, judicialization or something, that the patient recurred to the judge or the law system in order to get the treatment needed, like new drugs or such. And there is a huge, huge amount of money that is spent with these kind of patients. It's something about $5,000 million in this kind of burden. So 1 year of invasive cervical carcinoma treatment for the Brazilian population covered only by the public healthcare system, which is the Sistema Único de Saúde, which is the acronym in Portuguese for the healthcare system, which assists 75% of the total population, would be 25 million, almost $26 million. And another interesting fact is the low and middle income countries will nowadays have almost 90%, 85% of the global population, and will have 61.3 new cancer cases globally. However, it will only spend 60.2% in financials with cancer. So this count here, this sum will never go to the end for the poor countries or the low and middle income countries. But what about the cost of prevention? Here, another thing is that it's difficult to calculate the burden of treatment and the cost or investment, so to speak, in prevention, because there are not official studies about that, only segmented studies in some regions, in some institutions. Still, the PEP test here in Brazil is the one that predominates face the other kinds of tests. Still, we have, it's already an implemented program having screening by PEP tests, and the cost per test would be $11, almost $12. The cost per case would be per year would be 6,207, and it's negative here because this is the whole cost of the initiative when it costs that per year, and there is no reason to consider this an increment once it is already implemented. However, liquid-based cytology needs an increment of 10,150, almost to $200. HPV DNA test would be hybrid capture, which is better in sensitivity and better in accuracy, although more expensive, and will have a huge impact. PEP tests and DNA tests showed here in our country to be 97% sensitivity and 0.8 accuracy, and here it's a reasonable amount of incremental in the system. So we still see that even if it is in 1 year for 10,000 women, the long-term gains of this kind of testing will be better in due time, in middle and for, so to speak, long and middle term price terms of evolution of cancer cases. What about the cost of the active search per year? This is also an estimate that we have. We had to have 20 hours programming, and really it costs here in 1 year, and then the maintenance and something like that would be $352. We have, because of the system is totally automated, we have only 24 hours per year of our quality managed to collect the data and coordinate the distribution of forms with our collecting and delivering samples and report system. And it costs, this hour cost 1,600 reais. And the 24 hours deliveries, as well as papering and so on, so far almost $1,000, and the cost would be around $3,000. And here is because the logistics that we have is already implemented. So the active search cost is really, really low incremental to our system, right? Okay. But how we can dialogue with our authorities and show it all. Okay, we already know the costs. We have to open the doors. How we do that? With local medical association, with community councils, political association, we try to gather people and see the benefits and the costs of cancer and cancer prevention and so on and so forth. Sometimes it works better in the local aspect than in the country aspect, but it's needed. Global perspective, returning here to the investment. How can these foundations help? Well, WHO has a global plan in turning cervical cancer a rare disease and is gathering fundings in order to do that. So it's one thing. Another thing, EPUCG also can gather fundings for cancer research and control and invest in countries and in worthy initiatives. And here I will talk a little bit about the City Cancer Challenge Foundation, which is actually a spin of the EPUCG. It was created within the EPUCG because the proposal here was to try to control cancer in a more local aspect. So City Cancer, or CCAN, manages to create strategies to approach political and technical parties to the same table and help to develop sustainable cancer control initiatives at cities level. Like today, I believe CCAN has around 10 cities. The 4 key learning cities were Asunción in Paraguay, Cali in Colombia, Yangon in Myanmar, and Kumasi in Ghana. I work with the team in Asunción, and regarding the political aspect, Paraguay did not have a cancer policy written until 2018, so until 2 years ago. And another gain was that we could, working with the laboratories closely and trying to approach with the authorities to implement a regulation in order to provide a uniformity of working within the lab. So to guarantee a minimum of quality control for these labs in Asunción and diminishing of the turnaround time, of the time for release the report. So this here can be a huge force in assisting and helping our authorities to implement cancer policies. But considering that we cannot reach them, they won't open the door to us. The system, the active search of patients, like I described to you, is politician proof. It will work regardless of the policies, because still we can use the TBS system to make the categories, and we can still use international waiting times as the one reference for our establishing of criteria for automatization of the search. Okay, but what is the game for pathology laboratories? Here is something that I believe everyone is very curious about. Legal safety. This is one thing that I will share with you. Years ago, we had a legal suit for one patient that felt that herself was unassisted by her doctor and by the health system. So she sued her doctors, she sued our laboratory, and we would have to pay a legal amount of money in order to set an agreement. But when we had our hearing with the judge, and our technical director, Dr. Cecilio Fronza, which was one of the person that idealized this active search. He explained all the program to the judge, and the judge immediately ruled us out of the whole suit. So it was only for the doctor. So this can really, really save a lot of money and a lot of headache. Another thing, quality systems, laboratory systems that work with quality control can improve that earnings in two ways. One, improving processes and diminishing costs, right? Another, sharing costs with other entities and trying to show the importance of quality control for insurance companies. And we already have one or two policies here in Brazil that pays a little bit more to laboratories that have established quality control systems. Benchmarking within laboratories is very important. Like what we are doing here, we can do with our laboratories in our countries, in our cities, and try to make things better for everyone. Another thing is interlaboratory networking, and I will explore this a little bit. What is the important to have an interlaboratory, or the advantage to have an interlaboratory networking? To have external quality control. How? Today we have some government, some health system that demands for proficiency testing. It's very expensive to have regular proficiency testing in some settings, right? Especially in low-income countries. So what we propose here is that laboratories can share samples and diagnoses. So you send your specimens to another lab without the diagnosis. The labs read the slides and provides their diagnosis, and then we compare and see what are the discrepancies and why they had occurred. And then set trainings or whatever is necessary in order to improve the laboratory. Another thing is vocational specializations and test directions. What does that mean? Some laboratories are run by 2 or 3 pathologists that sometimes receive very little, for instance, hematopathology cases. So if we have a network of laboratories, we can send these cases to a partner laboratory and have them accurately read instead of losing time studying something that we are not very familiar with. And on the other hand, the other laboratory can send cases to us for the same reason. And especially in these days that digital pathology is evolving so quickly, it's very interesting to do that and very feasible. Sorry. Another thing, vacancy coverings. Sometimes laboratories will have, as I told you, 1 or 2 pathologists, and when one of them are on vacation, sorry, his vacation, and the network can cover that. Contingency plans, broken appliances, lack of human resources. So you understand, we can interchange resources and make a better work of what we have. And another thing is create a body of negotiations with suppliers for better prices and for insurance companies for better payment. So it's very interesting, the advantage that we can here. So we are competitors, yes, but we can compete in a friendly manner and even potentialize our capacities. We are only 1% of pathologists, considering all the other specialties worldwide. Cancer cases are increasing. We are extremely needed. So we need to find innovative ways to work with partnerships, to work with colleagues in order to improve our performance and deliver the needed care to our patients. So we have actually the key to start the change. We are almost done here. These are the take-home messages that I believe it's worth sharing. So considering all the results we have, the pathology laboratory is a key element regarding the care for cancer patients. Yeah, we have the screening, right? We have the analytical phase when we have the delivering of our diagnosis and reports. And also we have the post-analytical phase when we already delivered our reports, but we are still monitoring patients in order to detect them for the treatment when needed. Well, and since the lab has the basic data of patients and diagnosis, it's important to use these resources to reach the patients suspected of cancer, and also to share it with authorities. So specific policies can be made regarding local aspects. Considering that the rate of suspicious cases are really low compared to the total of tests of a given lab, there are many ways to carry out this initiative. It can be manual, or by phone, or automated. You can all have a spreadsheet and read the spreadsheet and set aside the case every month. So there's many ways that we can implement this. However, the role of the governments at any level represented by the health and sanitary authority or equivalent health surveillance system or sort, is to ensure that all relevant data are completed in the medical records, in the health system records, that the other doctors that send samples to us they have the conscience to complete the medical request properly. It's, I don't know, probably this is a huge aspect in many countries, not only here in Brazil. And so lab can act properly and really fast with more efficacy regarding the contact of patients. And another step to this system is to insert other types of tests and criteria. For instance, if we have first biopsies with a cancer diagnosis and no other test, positive tests of like breast cancer, prostate, gastrointestinal, other, whatever, we can set the criteria and make it a post-analytical aspect of our care for our patients and go after them. So I really think that is, as a race horse is a challenge, and we know that a horse can really cost between $1,000 and $35 million. We have to consider some facts about human lives. That anything can happen, yes, and bring consequences. However, we have the power or some power of control some facts of life by preventing disease. And the price of a horse is huge, but what to say the price of a human life, a mother, a spouse, a worker? So I believe we have here our share of commitment to help these patients and to decrease the cancer burden and doing our share of responsibility. Thank you for your patience. And please, if you want, I'm free for questions.
Thank you so much, Dr. Beatriz Hornburg, on enlightening us and giving us excellent coverage on this vast cost effectiveness of preventing cancer topic, and making us
Okay.
or making all the speakers, participants in this program even understand to that level of laboratory safety and all the measures that can be taken. And I had got a lot of inputs as well after listening to your. I'm sure that the other participants also would have got their inputs as well. It was a well
Okay.
detailed and systematic organized presentation with good statistic figures as well, madam. And I have also liked the way that the cost of prevention, the cost benefits, and the cost of active search per year has made a lot of difference on reducing or cutting down the number of cancer patients, which other
Yes.
countries can also follow the same concept like your country is following. And so with this, I would like to open the talk